All right, so I will take it for my presentation and just let us know if you have any questions. So I'm going to take you through lung screening and beyond, everything that entails lung screening and where to go when you have any unusual findings or even just how to manage a lung screen. Next slide, please. So we'll talk about today the importance of lung screening and how it relates to lung cancer. We're going to talk about management of lung screening findings and how we coordinate care for lung screening findings and adjusting to needs of our patients and any advances that we're doing within our lung screening program. Next slide, please. So what are some statistics about lung cancer? We know that lung cancer is the second most common cancer for both men and women. Lung cancer is the leading cause of cancer death compared to breast, prostate, and colon combined. Lung cancer mainly occurs in older people. Most people are diagnosed after the age of 65. A very small number are diagnosed younger than 45. And the average person can be diagnosed around the age of 70. However, I always mention to patients that anybody that has lungs can get lung cancer. Lung cancer is by far, again, the leading cause of death in the United States, accounting for about 1 in 5 of all cancer deaths. Each year, more people die of lung cancer than most leading causes of cancer combined. The two main types of cancer are the non-small cell, which accounts for 80 to 85% of all cancers, and small cell, which accounts for 10 to 15%. Typically, small cell cancer can be related to smoking, although not necessarily, but we do account for most of it being non-small cell. Next slide, please. So lung cancer is more common in men than in women, more common in Black men than in white men. Black men are more likely to be diagnosed at later stages, and Black women are more likely to be diagnosed at a young age with a less smoking intensity. Next slide, please. We're on lung disparities, yep. Okay, so I wanted to pay attention to this map here and kind of talk about some of the disparities that exist here in the Chicagoland area related to cancer and lung cancer in general. So if we look at the map on your left-hand side, we know that on the south side and west sides of Chicago, there is a lower socioeconomic status, lower poverty levels, lower education levels, and we know that housing is in poor conditions. There's less access to care in these areas, and these are the areas that are most impacted by lung cancer and cancers in general. We can see the darker the blue area, the more probability that someone is to die from lung cancer in these areas. It is a big difference from the north side where it's about a 2 times difference from the north side to the south side that you could have a lung cancer mortality. So what about smoking and why is that considered a disparity? Well, tobacco companies have targeted minorities and minority populations for experimental marketing. The tactic of encouraging consumers to experience or interact with brand or recreational venues and events such as concerts, bars, nightclubs, and has been a long tobacco industry strategy that they use to target these populations. Tobacco industry documents show that companies have used this type of marketing for decades to encourage people to experiment with tobacco and increase consumption, infiltrating their social activities and normal ways of living through tobacco use. Black individuals with lung cancer are 15% less likely to be diagnosed early and 19% less likely to receive surgical treatment, 11% more likely not to receive any treatment, and 16% less likely to survive from lung cancer. Sorry, give me 1 second here to adjust my slide. And so these are the disparities that we know with lung cancer are existing, and there's definitely many more, but these are the main ones that I wanted to mention. So it's time for a change. According to the CDC, breast cancer has a 90% 5-year survival rate. Cervical cancer has 66% survival rates, colorectal cancer 63%, while lung cancer only has a 24% survival rate compared to all other cancers. However, we do know that that is changing. Our 5-year survival rates for lung cancer are increasing, and this is due to different treatment options that are utilized to treat lung cancer, and most importantly of all, early detection. The 5-year survival rate for lung cancer drops dramatically from stage 1 diagnosis at a survival rate of 68 to 92%, than at stage 4 diagnosis, which could be less than 10% survival rates. In addition, the smoking perspectives are changing. As we are becoming more aware of how tobacco markets their products, the dangers that exist with smoking, it is becoming more common that people are realizing that and are aware of the changes that smoking can bring and the risk factors that they're exposing themselves to by picking up a cigarette. In addition, we need to address social determinants of health and in terms of getting screened, in terms of getting treatment, and recognizing that those are issues that impact lung cancer and lung cancer diagnoses. And of course, reducing these disparities overall. Next slide, please. And so how are we doing this? Well, one way that we have found is through lung cancer screening. And the goal of lung cancer screening is to screen high-risk individuals that have a potential to shift diagnosis to early stages and to decrease cancer mortality by detecting early-stage disease in high-risk asymptomatic individuals. And we'll be doing this through our low-dose CT scanner. Next slide, please. So what is lung screening and why a CT scan? The National Lung Screening Trial compared 2 ways of detecting lung cancer through CT scan, often referred to as a spiral CT, or a standard chest X-ray. CT uses X-ray to obtain multiple images of the entire chest, while a standard X-ray just takes one image of the whole chest, in which anatomic structures overlie one another. The study reveals that participants who received a low-dose CT scan had a 15 to 20% lower risk of dying from lung cancer than participants who received the standard X-ray. This is equivalent to approximately 3 fewer deaths per 1,000 people screened in the CT group compared to the X-ray group over a 7-year observation. On average, over the 3 rounds of screening, 24% of those low-dose CT scans were positive, and 6.9% of the chest X-rays were positive. So it's a big difference from 6 to 24. That's huge. Adenocarcinomas and squamous cell carcinomas were detected more frequently at early stages by low-dose CT scan than by X-ray. Next slide, please. So how do we describe and what entail, oh, actually, can you go to the one before? I'm sorry. So how do we describe and talk to anyone about what a low-dose CT scan is? Well, it does look like a big scary machine. I've had a lot of my patients tell me, oh my gosh, is it that big tube that I'm going into and I'm going to be there for a long time? Well, actually, I try to normalize it and tone it down a little bit. So I tell them this is going to be a 3D picture X-ray of your lung. It's non-invasive. We're not going to use any needles, medications. All you have to do is lie on your back on a table, possibly lift your arms over your head, and they're going to have you take a few deep breaths in and hold it, and then basically the pictures are done once you slide in and out through that big donut. It's a nice open donut, so hopefully it reduces claustrophobia for our patients. It's approximately 5%, 5 times less radiation compared to a regular CT for a low dose. Next slide, please. So what is the criteria for lung screening? Well, when we first started screening, the age limit was 55 to 80 with a 30-pack year history, and individuals who currently smoke or quit within the last 15 years. And then new guidelines came out. It was, I believe it was exactly March 9th of 2021. And what they did was they decreased the age to age 50 and decreased the pack year history to 20. And why did they do this? So the USPSTF has revised the recommendation for age and pack years for lung screening, as they wanted to increase the screening population that we were capturing. So we lowered the age and lowered the pack years to increase screening for a lower risk population that potentially could have been smoking at a lesser intensity, but perhaps over a longer period of time. Next slide, please. So what does a lung screening consult entail? So through our clinic, it actually has multiple parts. We'll talk about shared decision-making for lung screening, how we obtain smoking history and how we talk about that with our patients, risk prediction, carbon monoxide levels and education, tobacco cessation, and follow-up. Next slide, please. So what is our typical workflow for the lung screening process? So usually a provider will identify a patient that meets the criteria. They'll have the conversation with their patient to see if this is an appropriate test for their patient. The scan is performed and the patient will receive a scoring criteria, which is called the lung rads. It goes 1 through 4. Depending on which score the patient receives, it'll determine the follow-up that they need. So a 1, 2, or a 1 or 2 typically be an annual exam, and results will go back to their provider and follow up with the patient annually. A lung rads 3 will probably require an interval exam before that year, so possibly at 6 months. And again, it's something that you could just order a CT scan in clinic and continue to follow your patient. Typically doesn't require any other testing unless your patient has having any other symptoms. And a lung rads 4, so that's a little bit more detailed. Depending on what we're seeing on the scan, we might have different referrals to different departments, additional testing. We'll discuss it with our multidisciplinary tumor board. And once we come up with a recommendation, it comes back to the patient and we discuss from there what are the best options for them. Next slide, please. So a little bit more about our centralized program and how we manage our patients in clinic. So we identify the high-risk patient. Sometimes we get referrals from our primary care providers, surgical department. We can have many avenues through where we can consult a patient for lung screening. And what we do in clinic is we'll go through their risk factors, assess their criteria, and recommend a low-dose CT if they do meet that. We follow up with the patient with next steps once they receive their results, order their next low-dose CT, and ask the patient if they're willing to interact with ongoing smoking cessation, if that's appropriate for them and they're ready to do that. If the patient does meet a lung rads 4 criteria, we are a little bit more aggressive in care coordination and how we manage these patients. And we ensure that everybody on our multidisciplinary tumor board is aware of these patients, and follow-up is followed very closely to ensure that patients are getting in a timely manner for their follow-up appointments. All this while communicating this back to our referring providers, whether it's primary care or from wherever the patient is coming from. We keep a close loop with everybody and ensure that that communication is open. Next slide, please. So what do we talk about in shared decision-making? So we want to ensure that patients understand the importance of adhering to an annual low-dose CT scan and how that can change early detection of lung cancer. We discuss the impact of other comorbidities, their ability to and willingness to undergo diagnosis and treatment, and counseling on smoking cessation. Now, a shared decision-making visit is billable, and we included the code here, and it's without cost sharing to our patients. So we want to keep our patients informed, ensure that they meet criteria so that they're not getting any denials, adding on stress. We just want to make sure that this process is as smooth as possible for the patient. And of course, it's a decision that we'll make together, and ensuring that the patient is agreeable to pursue an individualized care plan for their lung screen. Now, a couple of important codes. So having said, I briefly mentioned denials earlier. The only two codes that are currently accepted for a lung screen are these two here. The Z87.891, which is for a person with a previous smoking history greater than 20 pack years. And then the F17.21 for currently smoking. I can say that I've had many times where I've helped many providers with denials, because they might be entering the order under perhaps pulmonary nodule, or they might be entering it under screening for lung cancer, which I believe is more of a preventative ICD code. It strictly has to be those two codes, because otherwise their insurance will deny it, even though you have proof and have documented that the patient does meet the criteria. So it's very important, just if anything you take from that slide, just remember those two codes, because that will ensure that your patient gets approved for their screening. Next slide, please. So when we talk to patients about their smoking history, usually I will like to ask patients, so tell me a little bit about your smoking history and how many cigarettes are you smoking today? So if they tell me today 5 cigarettes, okay, great. And then what is the age that you started smoking? Most often I'll get an age anywhere between 16 and 18 is the most average, but I've heard as young as 8. And so it just kind of depends. Oh, I'm sorry. So it just kind of depends on the patient, and we try to calculate from there. However, there is one question that I always ask patients. What is when you were smoking at your most intense time, how many cigarettes a day are you smoking? And they'll often tell me, okay, well, at that, maybe in my 30s and my 40s, I was smoking a whole pack or a pack and a half. And so how do we calculate this? Well, we know that in a pack of cigarettes, there's 20. And so let's say they were smoking from age 25 through 50, they were smoking 1 pack a day, and then they decreased it from there to 5 cigarettes. So we know at least that patient has definitely a 25 pack year history, given that they were smoking that whole pack. Now, sometimes patients will tell me, I was smoking 10 cigarettes over the last 40 years. Well, that'll equate also to a 20 pack year history. So we just go through that in detail. We also account for perhaps in women, if they quit smoking for their pregnancies, or if they had quit during certain periods of time. So we kind of discuss that in detail. And next slide, please. So another thing that we talk about during a lung screening consult is our risk calculation for lung cancer. So it increases the accuracy of a 6-year lung cancer prediction. It's another effective method of screening. And other factors are accounted for, so not just pack years and age, but also family history, other comorbidities such as emphysema, COPD, prior history of other cancers, cancers in the family, their education levels, and their race. And we come up with a percentage to determine if this patient meets a high-risk criteria. And it encourages patients to continue their annual screen if they know that perhaps they are not having any symptoms right now for lung cancer, but they know that they are high risk, and they're able to see their numbers and know that they are meeting high risk criteria. So it helps with patients returning for annual screenings. Next slide, please. Okay. So another thing that I go through with my patients, if they are open to it, is carbon monoxide level education and screening. So what I utilize in practice is this little machine that's the carbon monoxide detector. It takes 15 seconds for the patient to do it. And they often just have to take a breath in, hold it for 15 seconds, and it populates a number. Normal reading would be anything under 6. And I'm sorry, I think my, yeah, it's for some reason my format was changed. So a normal reading would be that of 6. And that would be for anybody just breathing normal room air. Anything higher than that, they might have either had a cigarette prior to coming into the appointment, or it just kind of depends when they had their last cigarette, but we can get elevated readings up to, I believe the highest I've seen is 25, and that's somebody that's smoking quite heavily. Next slide, please. So we talk about smoking cessation during our visit if the patient is open to receiving the information. We discuss options, whether it might be medication options, nicotine replacement. We talk about behavioral modifications that a patient can do to help them with their smoking cessation journey. And we underline other comorbidities such as, do they have high blood pressure, diabetes? Are they undergoing surgery and are trying to meet a goal of a surgical day to quit smoking? So we adapt our smoking cessation plan according to the patient's need. Next slide, please. So my first smoking cessation go-to, and depending on the patient, if they're ready to start this, would be nicotine replacement. And I talked to them about the different ways that nicotine is delivered through these nicotine replacement systems. And the first one is the nicotine patch. It does come in different in different dosings, so 21 milligrams, 14, and 7. It is a long-acting formulation, so when the patient applies the patch, they can apply it to either side of their arm. I even say often the upper back is an acceptable area as well, just depending on what site they want to switch to so that their skin doesn't get irritated with the adhesive. And it is a long-release nicotine replacement, so it gives them a nice steady dose of nicotine release throughout a 24-hour period. And at the 24-hour period, we want to make sure that they're switching their patch and switching sites to where they're putting it on. Now, dosing will depend on how many cigarettes they are smoking per day, because we want to adjust to ensure that they are not going through withdrawals from the amount of nicotine that they're intaking during their smoking. So if they're smoking more than 10 cigarettes per day, we definitely want to start them out at the higher dose, 21 milligrams, and then titrate from there depending on how the patient is doing when you follow up with the patient. It could be at 4 weeks or 6 weeks, just kind of depending on each case. And if they're smoking less than 10 cigarettes, I would start them out at the 14 milligrams so we don't overload them with nicotine. We want to make sure that we start them out at a nice steady dose appropriate for what they're smoking. Next slide, please. Now, so the short-acting nicotine replacement would be something like the gum or the lozenge. So the gum and the lozenge come in 2 doses, the 2 milligram and the 4 milligram. And usually this can be added onto their plan depending on when they have their first cigarette during the day. So this could be at 30 minutes of waking up. You might want to start them out at a higher dose because we know that they are dependent on that nicotine and we want to prevent them from smoking the cigarette. I'd rather they have that piece of gum. And so we would start them out at the 4 milligram, and they can have a piece every 1 to 2 hours. The important thing with either of these short-acting formulations, they'll receive the nicotine a lot faster than with the patch, which is kind of similar to smoking a cigarette, in which nicotine reaches the brain receptors that accept nicotine within 10 seconds when you inhale with a cigarette. And the short-acting replacement is somewhat similar, but you have to ensure that you are chewing, for instance, if it's the gum, you want to ensure that you're chewing it and parking it in between your cheek and your gum for at least 30 seconds. So I tell them, chew your piece of gum, park it in between your cheek, and then leave it there, and keep repeating it until that flavor is completely gone. And that allows it to absorb into the capillary system so that it can reach the brain, as opposed to being digested by stomach acids, and then the nicotine replacement won't work. And that's kind of often what I review with patients when they're like, oh, I've tried nicotine replacement, it doesn't work for me. Well, I'm like, let's review how you're doing it. What is it that you're doing with the gum or the lozenge, just to make sure that they're doing it correctly. And then another thing I always ask patients is, do you have dentures, or are you able to chew gum? Because we want to make sure that we're giving them the appropriate nicotine replacement, not just saying, oh, here you go, here's some gum, and they might not be able to chew it. So those are the things that I consider when adding the short acting onto their smoking cessation plan. Next slide, please. Okay, so the next slide is our medication that I often go, it's my go-to medication, I would say. There are other medications that we can use for smoking cessation, but I would say varenicline is just easy for patients to start. It's easy to follow up on patients, and it comes in a nice little starter pack so they can adjust to the dosing. It does help with the cravings and withdrawal. I always tell patients that you want to initiate at least 1 to 2 weeks prior to your quit date, because it does take a little time for it to level out in your system and get that full benefit from the nicotine receptor agonist. And so what happens is, when I prescribe this to a patient, it comes in a nice little dose pack where it tells them how they have to take it on days 1 through 3, 4 through 7, and then beyond that once they get on their maintenance dose. This little picture here with the starter pack is for about a month's worth of varenicline. And then after that, we can just prescribe varenicline 1 milligram twice a day if the patient is tolerating it well. So we do adjust for renal dosing. So if it is a patient on dialysis, we want to start them out at only the 0.5 and maintain them on that dose only, so we can adjust for the renal clearance. And then side effects that I talk to patients about typically is nausea. So we want to make sure that they're taking it with the full glass of water, and at least having a little snack or something in their stomach prior to taking it. Sometimes patients are like, well, am I supposed to take it just in the morning because I don't eat in the morning? Or do I take it at night? It just kind of depends on when they're eating. It's okay. I always tell them, take it with your right after your first meal, and take it with your last meal of the day. So then that way you have enough space during the day, because we have to adjust to what the patient needs. Next slide, please. All right, so lung screening and follow-up. So what are we going to see on our lung screenings, and what do we have to do when we have these when we read these reports? Next slide, please. Okay, so just very briefly about the Lung-RADS scoring criteria. This was scoring criteria set up by our American College of Radiology, and it's very simple to follow. It gives us our scores 1 through 4. Sometimes it does give you a 0. So if, for instance, a patient was moving too much in the scanner, we couldn't get a good, clear read, they'll often tell us to repeat it in about a month or 3 months, depending on the patient's need. A Lung-RADS 1 basically means that the scan was negative and there's no nodules of concern. So we'll just proceed with annual screening. So if the patient's meeting that high-risk criteria, we want them to come back every year, regardless of not seeing any nodules. A Lung-RADS 2 would be something benign. We might see a few nodules that are probably less than 6 millimeters. And again, these are benign findings, so we definitely want to just follow up with that annual screen. A Lung-RADS 3 is probably going to be benign, but we want to make sure as the patient is meeting the high-risk criteria, so we want to follow up a little bit closer with them with a 6-month scan. And again, that's just depending on the size of the nodule and the classification of the nodule. So we want, if it's between like a 6 and 8 millimeters, I usually tell my patients, I'm going to see you in 6 months for another scan. This nodule is not large enough for additional testing besides a CT scan, but we want to watch it closely to make sure it doesn't change. And then we go into a Lung-RADS 4 criteria. And that is categorized into 3 different areas. So we have our lung RADS 4A, where we're concerned about it because it is over 8 millimeters. And there could be some suspicious characteristics to the nodule. So depending on the patient, when I talk to them and consult with them, if they're having any symptoms, anything unusual that they've noticed, I might either decide to proceed with a low-dose CT scan at a sooner interval, so possibly at 3 months. And this low-dose CT scan is different from screening. It is diagnostic versus a screen. And basically, the only thing that changes is the ICD codes for that. So Medicare will only pay for 1 screen a year, but if you do need additional testing related to an abnormal finding, you want to ensure you order a diagnostic so that the patient is not getting, again, a denial because they need this interval scan. And then we can also, if the nodule is large enough, so if it's over 8 millimeters, some scanners might say 9 millimeters, you can get a PET scan, and that is a more in detail exam that can help us detect any abnormal cells and potentially lead us to biopsy the patient. A lung RADS 4B. So again, it could be like a growing nodule that has been over 8 millimeters, or something unusual about the characteristic of the nodule. And we most often might go for a PET scan at that point, or biopsy if possible. And the biopsy would be, if our tumor board recommends, our biopsy would probably be done via bronchoscopy or ion bronchoscopy, depending on the findings that we see within the nodule and where it's located. And we set that up for the patient. And if 4X is definitely a very suspicious nodule that we would right off the bat go for biopsy if possible. Next slide, please. And so what else can we see in a low-dose CT scan? So we're scanning basically from your chin, you could say, all the way down to possibly like can capture some of the kidney as well, and a little bit more and beyond. So we definitely have incidental findings. We can use this and show our patient, this is your nodule. So as we can see in this first image here, this is what it looks like. This is where it's at. And I describe other features in the picture, like this is your heart, this is your back, and what we're seeing on the picture. Well, I call it picture for our patients, but these are the images that we see. And then other things that we can see, again, so I go through those incidental findings with the patient. So I talk about emphysema. So, the patient might come in and they're like, well, I don't have any problems with my breathing. I don't have any issues. But then I show them their scan and I'm like, you're starting to have some changes in your lung. And once they see it, it's pretty impactful for them to see. And they respond to that and they're like, well, maybe it's time I start making some changes. So it's definitely something that is eye-opening to them. And another thing that I like to talk about with their scan is the coronary artery calcification. So we can see that in the picture there on the arrow. It's kind of the little white spots in that area. It's more dense than the other area. And that's when we see the hardening, the atherosclerosis in the artery. And I talk to patients, I'm like, have you ever experienced high cholesterol? Are you taking any cholesterol medications? You probably should be taking cholesterol medications if you're not, and just kind of have that conversation with them just very briefly. I've had patients tell me like, oh, my doctor says my cholesterol levels are fine. I stopped taking my pill because I just don't want to take an additional pill. And then I show them, I'm like, well, maybe, might be a good idea to continue that on unless your doctor says it's okay to stop it, because we are seeing those changes on your scan. Okay, next slide, please.
Marisol.
Oh, yes.
Marisol, I had a quick question.
Yes.
Dr. Mance, I majored on. So what I'm seeing here is the aortic calcifications. Can you actually see the calcifications in those arteries surrounding the heart?
I'm sorry, I couldn't hear part of your question.
Okay, I'll speak slower. What I see here in this picture is aortic calcifications.
Yes.
Can you actually see calcifications in the arteries that supply the heart muscle itself?
If you scroll through some of the images, you would be able to see that.
Wow.
Yeah,
Cool.
so it's kind of just a nice teaching point for the patient so they can actually see what's inside of them, basically. I mean, you're not feeling it, you're not experiencing it yet, but it could be a call for change for them. And some of the other
Right.
incidental findings that I've found as well is like a thyroid nodule, or sometimes an adrenal gland that's enlarged, or a nodule, sometimes a kidney cyst, liver cyst, things like that. So we talk about all those things in addition to just the more concerning findings.
That's great. Thank you.
Oh yeah, no problem. So what we do with what do we do when we have these findings, and where do we go? So lung screening coordination has been a big factor in ensuring that our patients receive the proper care for these incidental findings, for any additional referrals they may need, for any additional testing. So we recently acquired our full-time lung screening coordinator, Victoria Smith, and she has been wonderful in helping us coordinate all our patients. And so she manages right now referrals from our external partners. So if a patient wants to come in and they're not part of the UI Health system yet, she ensures that the patient can navigate through our system and get their screening. She will assess for social determinants of health if there's anything impacting the patient that would need a little bit more coordination coming in from the community to UI Health. She would help out with that. One big thing that we help out with is transportation. So if a patient is having difficulties getting their screen and they maybe don't have a ride, or they can't pay for parking, we do help with those things as well to facilitate their screen. We have partnered with our radiology scheduling team. So if we have certain time slots for low-dose CT, so if the patient can't make it to that because of work or whatever circumstance it may be, we do address it with our radiology scheduling team, and they have been wonderful at accommodating us and trying to get our patients in, because that scan is so quick that they can just squeeze somebody in within 10 minutes, which is kind of nice. And then she also reviews the smoking history to try to have that as much up to date as possible before talking to one of us if need be. And she eliminates that workflow barrier for patients to, possibly get a referral at their clinics, and they're like, here you go, here's a low-dose CT scan for you. Good luck on finding a place to get it, or how to even get it. So when we receive that referral from the external clinics, she reaches out. She's very proactive about reaching out to our patients and letting them know that a screen was ordered for them, and if they would like to schedule it here, or if they're having any other issues with scheduling, she'll assess that as well. And again, it provides a direct point of contact for any questions. If the patient is not sure about what a lung screening is and they want more information, they'll schedule a telehealth with me or Mary, and we can talk to the patient via telehealth or in person if they'd like to, just about what a lung screening is, and go through that in detail with them so that they have a little less anxiety when they're coming in for a lung screen. Next slide, please. And some of our highlights that we've had with our program is we've been very active in the community in the last year, reaching out to many organizations, educating on lung screening, trying to get patients connected to a lung screen within their area. Dr. Kovitz has been on WGN for our Spotlight Chicago, and talking about lung screening and the importance of it. And I mean, I think our team has done a fabulous job in trying to create that awareness and reducing the stigma that comes with lung screening. Most often patients are very afraid when they hear the word, oh, I'm getting a lung screen. Why am I getting a lung screen? And so we talk to them and try to create that awareness that it's a normal part of screening, and we should get it done because it changes the way we're diagnosed and detection. And we just want patients not to be afraid of it. So we are creating that awareness. Next slide, please. And one thing I always like to mention is November, because that is our lung cancer awareness month. Again, coming in with that stigma, many of our survivors and patients that have been diagnosed with lung cancer do not like to speak up about it, but it is something that we should know. So I always highlight that the ribbon color is white. So around Lung Cancer Awareness Month, I always wear my white ribbon. And a good organization to look at is the White Ribbon Project. It advocates for lung cancer, education on lung cancer and how to participate in events. The education not only is for patients and families, but also for providers and how to speak to patients and how to discuss lung cancer screening with them, lung cancer and any topics related to that in a sensitive manner that can help patients keep coming back for their care and not be stigmatized for something like lung cancer. Next slide, please. I wanted to play this brief video. It's just a visual aid that I like to use or sometimes recommend having it in a waiting room. So if you don't mind playing that for me, Deb.
I hope the sound works.
Okay. Oh, maybe not.
Sorry, can you hear it?
No, it's okay. We can hold on to it. I will definitely put the link in the chat to it if anybody is interested in watching it. But it is a visual aid that I use with patients sometimes to kind of summarize what a lung cancer screen is. It was created by the GoTo Foundation, and it talks about lung screening and how it's saving lives in a quick 2-minute clip about what it is and just a nice visual for patients to have. So I'll put that link in the chat for you guys. And go ahead to your next slide. So it does take a village to manage our lung screening patients. It's not only me or it's not only internal med's responsibility, it's everyone from radiology to scheduling, endoscopy, allergy, oncology, just to name a few, cardiology, endocrinology, everybody is literally involved in a lung screen. And so it does take a village to care for our patients in the lung screening program. And most important is the patient. And that's what we will surround them with all the support that they need for that. Next slide, please. And I want to thank everybody for being here today. If you have any questions, please feel free to reach out to me. I see a few questions in the chat, so if we can address those. Let's see here. Okay. Deb, do you want me to read off the questions?
Yeah, go ahead.
Okay. All right. This one is from Mayonette at Wellness House. So how does height impact risk criteria? That's a good question. So it is, again, so height and weight, we use BMI as a risk factor for lung cancer screening in the risk prediction model. So it's not, I don't think it's particularly height, but I think it's more of the BMI that is a factor in contributing to lung cancer. I don't think it's a direct link, but it is part of the risk prediction. I hope that answered your question.
That makes sense, Marisol.
Okay.
Thank you so much.
Okay.
Yeah.
All right. And then Genesis asked, how does vaping and marijuana smoking impact screening recommendations, if at all? That's a very good question. So right now, I would say that lung screening is going to continue to change. Right now, the criteria does not cover for vaping and marijuana, but we do assess that during our smoking history. So I do often ask patients, any other kind of smoking, anything else that you might be inhaling, any other drugs that you might be inhaling, because that all definitely plays a factor into their lung health. Screening might not be covered for those particular inhalants, but it's definitely something that I would assess during their smoking history and see if they're having any other side effects related to their vaping history or their marijuana smoking history. And I always tell patients, anything that you inhale that's not oxygen is probably going to affect your lungs somehow. So I do talk to them about that. And I do mention that it's always just good to continue to follow up and any symptoms that they're having, any changes to their breathing that they're noticing, even just as simple as maybe 2 months ago, I was able to walk through blocks and I felt normal. And then now I've been noticing some shortness of breath. So those little things I talk to patients about their activity and ensuring that they're noticing those changes. Genesis, any other clarification on that?
No, that makes sense. Thank you so much.
You're welcome. And then are there any resources, this is from Jessica, are there any resources for uninsured patients to receive the screening? I'm thinking patients under 65. Okay, so so screening is covered for anybody between the ages of 50 and over, as long as they meet the criteria. Prior to that, unless their patients are having any symptoms under the age of 50, they wouldn't be getting a screening. They might be getting a CT test for different reason. Maybe it's a persistent cough or shortness of breath. However, if patient doesn't meet any of those criteria, they're not having any symptoms, I often run through the risk prediction if there's been a family history. And sometimes I also use again, it takes a village. I refer to genetics as well if need be, so that they can do a little bit more investigation about their history and their genetics that can play a factor into their lung cancer diagnosis. And in terms of the uninsured, there are some resources. So I know with UI Health, we do have charity care. And that would be, I believe that is something that has been covered in the past before. That would be something I would usually refer to our care coordinators in that department. But I often check in with them if there's any resources available to patients that are uninsured.
Thank you.
Oh, you're welcome. And then Mayonette, so I'm just going to read out the question. You mentioned the disciplines involving and supporting lung cancer screening patients. What about referrals for psychosocial support? Yes, definitely. So that is, I don't have any particular, like for instance, for therapists, any particular organizations that I refer to. I would love to start developing those resources for patients, but I do ask about their mental health because sometimes patients are smoking. It is often related to stress or anxiety, depression, many mental health illnesses that impacts why they're picking up that cigarette and reaching for that gratification with the nicotine. So I do ask them about that. And, you know, I do talk to them about if they're on medications, if they need to speak to somebody. I'll provide them sometimes with the psychiatry referral if needed, or encourage them to talk to their primary care provider if they need additional referrals for any mental health resources. But thank you for that question. And it's also encouraging me to expand my horizons a little bit with that.
Yes, it was a little bit of a shameless plug. We do have a lung support group as well at Wellness House. So would love to connect with you maybe afterwards about
Yes.
how to connect your
Yes.
patients with our programs. Yep. Thank you.
Thank you. Yes.
Yeah, thanks, Magnette. You got also the oncology social workers, I'm sure would be glad to see and talk to any of your patients you have a referral for. But yeah, definitely Wellness House. And I know there's many other lung organizations as well. We could talk more about that. If anyone has any other ideas, definitely send us a message in the chat or an email. Thank
Yes,
you, Marisol, for taking
you're
this over.
welcome.
Hey,
You're welcome. I
Marisol, this is, oh, sorry. This is
No, go ahead,
Nicole.
Nia.
I had a quick question as well.
Sure.
This was super helpful. Thank you. This is so important and so clinically relevant for our patients. In terms of medications, I know one of the medications you mentioned was Chantix. Just like anecdotally, I've had a lot of patients nervous to take Chantix because they've said, you know, they've used it in the past, or somebody that they know had like really strange vivid dreams or something to it. So for some reason, that medication sometimes gives patients a lot of anxiety, at least in my experience. With one of the ones that sometimes I reach for is Wellbutrin. Do you have any thoughts on that medication, if that's effective or?
Yeah, I mean, I have had a few patients on Wellbutrin as well. Usually it's not my first go-to, just because there's a little bit, sometimes there could be other factors related to the Wellbutrin use, so of course with depression. But I have had a few patients on Wellbutrin. They haven't reported as much success as with the varenicline. So I tend to lean a little bit more towards the varenicline. And if that's not an option for them, I do talk to them about the nicotine replacement first before I go to any other medications, just because the goal with starting a smoking cessation plan for a patient is to even just get them to decrease their cigarette use. I always tell my patients when I start them on something, you don't have to quit today and you don't even have to quit tomorrow. But if you can work on decreasing little by little, that's a big impact. So if they're not ready to start varenicline with my practice, I often talk to them about the Wellbutrin and see how they feel about that. If they wanted to try it, I do tell them it's an antidepressant that can help them with smoking cessation. And I've had some patients that actually are on Wellbutrin and they're like, well, I've noticed that I have decreased my smoking, but I'm not there yet. I'm not feeling like I can fully quit with it. So we do add on varenicline onto that already. So it just kind of depends. We have that conversation. If they're not ready to start varenicline, I don't push them on that or anything. I acknowledge their concerns and talk to them about it. I've had patients tell me, oh, I've taken varenicline. I cannot take that medication. It's giving me a bad reaction. So we just tend to lean more to behavioral modifications, whether it might be decreasing the time that they reach for their coffee and their cigarette at the same time, or if they pair it with food. We talk about other resources that they can use first, and then keep exploring options as we go through their screenings.
Thank you. I really appreciate that. I think it's super helpful, and I totally agree. I think any progress that you can make, even if they're not quitting, if they're cutting down, I think that's success. So thank you for bringing that up.
Yeah, thank you. Yes, I definitely applaud them. Anything that I see that has been a change to decrease, I always tell them that's wonderful. You're doing it. So, I mean, that's definitely a positive impact that they have. I can see a change in their face because they always walk into the office and they're like, well, I haven't quit. But I'm like, that's okay. So what have we changed? What can we do to help you with that? So we explore those options.
Yeah, it's all about taking those little behavioral lifestyle steps, right? I know I worked in the smoking cessation clinic in residency, and it was always about, like you said, giving them credit, like you're saying, Dr. Awadi, baby steps with that. Thanks for asking that question. When Chantix came out, I remember I was working in a free health clinic, and it was the number one problem coming out. Everyone was talking about these weird dreams, people having, tendencies, and it was kind of scary. So I really hesitated to use this med. So I'm really interested to hear that this was kind of a first line for you.
Yes. And yeah, again, it's just about acknowledging those patient concerns and having them start on something, whether it's just the nicotine gum, and those behavioral modifications is better than nothing. So.
Absolutely. Absolutely. Well, again, sorry for my technical difficulties. Thank you for a wonderful talk, Marisol. A lot of information that I'm sure most of us had no idea about this lung cancer screening. And I remember hiring you about 4 years ago, and what a progress you have made with this program. So very grateful to have you on board and part of the Cancer Center and part of the cancer prevention team. So I know it's after 10. If anyone needs to hop off, you can. But if anyone has any other questions for Marisol, do you have anything to rush to? We can just see if anyone else has anything else. But thank you, everyone, for coming.
Thank you, everyone.
All right, everyone, have a great day. I'll send out email shortly with the recording, and I'll get my audio working for next time. Thanks so much. Bye, everyone.
Bye. and just let us know if you have any questions. So I'm going to take you through lung screening and beyond, everything that